So we got our first tomotherapy machine, if I remember well, at the end of 2005. Yes, December 2005 we did treat our first patient, and then we got our second machine, if I remember well, in 2011 or early 2012. And then 2014, early 2014, we got an upgrade of these two machines to have the iArt with the Volo and the Edge system. So it has been almost 10 years experience with the first Tomo machine. In a way there is no difference, but in a way there are plenty of differences. I decided to buy a tomotherapy machine in 2005. I made a comparison with all the options, and at the time we concluded that it was, let's say, cost effective, quoted unquoted, to buy a tomotherapy machine, in the sense that the quality of the dose distribution at the end and the time, the investment, when I say investment, it's not only the money, it's investment from my side, it's investment from the physics side to do the planning, it's investment from the RTT side, it's all the link in the chain network was in favor of a tomotherapy machine for the implementation of IMRT. And then I have to admit that with the latest system, with the Volo and the Tomo Edges, and of course also with time, the not reliance or the quality, the uptime of the machine became better and better. And I think our latest figures in-house, it's an uptime of 97-98%, which is number one acceptable for a routine clinical point of view, although it could be better, but it can always be better. But it's also absolutely comparable with other vendors. So we are using extremely sophisticated equipment. They are all vendors are providing extremely specific equipment. So it means that we really push the machines up to the limit, and which can then, I guess, explain that we are not getting 100% of uptime. Myself, I only treat head and neck. But I can tell you that from the beginning, so from 2005 on, 100% of my patients gets a Tomo dose distribution. Now my colleagues doing cervix and GI and lung and brain, sarcoma, they also all use IMRT with Tomo. So in fact, in our center, which is an academic center treating 1,200 new patients per year, 50%, so 50, of the patients are getting IMRT. The one who are not getting IMRT is for palliation, and for few breast cancer patients also do get tomotherapy, I guess mainly for left breast. We treat all cancers in our department with IMRT, with Tomo. So what we have in head and neck cancer, as you know, let's say the characteristics of the head and neck cancer patients, or I should rephrase, the characteristics of the head and neck target volumes are, number one, it's quite typically large target volumes because it include the primary tumors, but also the neck nodes, and so we can typically have in the craniocaudal direction from 15 to 20 or even sometimes more cm, so it's quite a large target volumes. Number two, the shape of the target volumes can be quite different. It may start with a kind of horseshoe shape, and then at the end finish like a spike when you are close to the retrostyloid area, for example. So the complexity of the shape of the target volumes is another characteristic. Then there is a third characteristic, which is that the target volumes are extremely intricated with the normal tissues. The parotid gland is close to it, the spinal cord, the brainstem structures, if you speak about tumor high up in the neck. And all of these characteristics makes the dose distribution quite critical. And so that's why whatever the solution you decide to take, it needs to be a solution that fits all the requirements that I just mentioned. As I mentioned earlier, one of the reasons why we decided back in 2005 to go for a Tomo machine is that everything was quite very well integrated. Of course, we use another delineation software, but that's fine. The QA of the planning, and also the machine or the workup or the interface, the interface that we use on a daily basis, or that the RTTs use on the daily. Everything was clearly fully integrated, and it makes the process much more fluid, much more straightforward. And it was also a reason why we decided to go for that technology. One or two criteria that I'm using. First, the dose distribution, number one. It needs to be fully homogeneous within the target volume. So without any heterogeneity, and we have constraints to accept or not accept the heterogeneities. And of course, it needs to be very good dose distribution to spare as much as possible normal structures. And obviously that's IMRT. From the patient point of view, the dose distribution is clearly an important aspect. Second, from the patient's point of view, is treatment time. And indeed, with the new Tomo H and Volo, and the possibility to use larger field size, so typically the 5 centimeter width compared to the 2.5 centimeter width, allows us or help the patients because it reduces typically the treatment time by a factor of 2. So that's from the patient point of view. For the people involved in the treatment, so physicists and RTTs, the fact that the flow is so straightforward makes it, in my opinion, clearly something which is quite advantageous. And as I already mentioned, it's part of the reasons we decided to go for Tomo equipment. I think it really depends on what you do. If you mainly treat palliation or palliative patients, then I think you need simple equipment. You don't need to have fancy dose distribution, and so there are, I guess, other equipment which would do it very well on the market. If you want to do full IMRT and possibly adaptive IMRT, and you have more difficult cases, and I believe head and neck is clearly part of the definition of a more complex cases, I believe that tomotherapy is really quite cost effective.